cell-free DNA, and all the work that OHSU has been doing, and he has been the champion for it. So you'll hear something outside radiation medicine per se, but very much within oncology.
Great. Thank you, Liana. Beautiful, beautiful introduction. I really appreciate it. Yeah, so I'm a radiation oncologist. Thanks for having me be part of this group here. And another role that I have within the Cancer Center is the Director of Early Detection Clinical Research team. And we have a multitude of early detection clinical trials, largely looking at blood-based genetic tests for cancer screening. And it's been an exciting, year or so with some data finally maturing that I could kind of include in my talk rather than, giving a super high level talk like I'd given previously. So here we go. Let me get this connected. So here are my disclosures. I will be talking about products from these companies. I have consultant arrangements, and specifically with Grail. I have a consultant agreement with them where I help with diagnostic workup for patients across the country who have received a multi-cancer early detection signal positive test. These are very new. Primary care providers, largely in concierge settings, are the ones ordering these right now in the commercial setting. And it's early days, and I interact with them, nationally, trying to help them and guide them to diagnostic workups. So our learning objectives will be to review the currently available recommended cancer screening strategies. I'll introduce the concept of blood-based multi-cancer early detection technologies. The acronym we use in the field is MCED or MCED. We'll also talk about the development pipeline of these types of tests. And we'll review current results from early clinical trials. And then we arguably have one of the world's largest experiences in providing these tests and working up signal positives. So we've amassed a portfolio of case vignettes, some very interesting that I'll highlight at the end of the talk. So this is a huge challenge and conundrum in oncology. This is a patient who is found to have a intrahepatic mass, ultimately deemed to be an intrahepatic cholangiocarcinoma. There's currently no screening techniques available for a cancer like this, largely because the incidence is so low, about 1 in 100,000. So certainly not high enough in prevalence for us to, talk about single organ cancer screening for cholangiocarcinomas. Early detection for a cancer like this is essential because the median survival for an early detected resectable intrahepatic cholangiocarcinoma, as you all know, it can be good, median survival around 5 years. Whereas an unresectable cancer, imagine those patients who present with painless jaundice and an extensive mass involving the hilum. Median survival for unresectable cancer is less than a year. So it's clear that we have to do better to try to identify these types of cancers at early stages. So in the US, we have something called the US Preventive Service Task Force, which provides guideline-based recommendations for cancer screening. The cancer screening is graded A, B, and C. A and B are largely the ones that are recommended by the task force that then insurance covers. And currently, there are only 4 cancers that have level A or B guideline recommended cancer screening tests. Those are for breast, cervical, colorectal, and lung cancer for those eligible. As you can see here, the sensitivity of these tests are quite high. But the specificity of these tests struggle. In turn, the positive predictive value or the likelihood that a positive test returns with an actual cancer are quite low and below 10% and around 5% for things like mammogram and colonoscopies. You can also see adherence in that right column. Adherence for these tests is pretty poor too. Population-based wise, we've done a really good job of cervical cancer screening. But you can see lung cancer screening for those eligible, it's pretty dismal in the US, and in Oregon it's even less than that. It's right around 10% of people that are eligible for lung cancer screening are able to get the test. You'll see that prostate cancer is missing here. Prostate cancer is a level C recommendation from the task force, and that means it's an informed consent process between the provider and the patient. there's a lot of controversy in regards to prostate cancer screening. So this is a hypothetical patient. This is a woman, a 60-year-old woman who's a smoker, who is eligible for all 4 of these screening tests. And you can see that there's a 43% chance that any one of these tests may return as a false positive. And this is something, and this is part of the contract that we've signed with these cancer tests with very high sensitivity, that we're going to be picking up many things that aren't cancers. And providers are accustomed to navigating patients with false positive findings. And in some way, patients are also getting used to this too. But this is something we're dealing with practice today. And certainly there's room for improvement here as well. And then furthermore, cancers without recommended screening tests account for the majority of cancer deaths in the United States. You can see that, those four or five cancers correspond to about a third of the cancer-related deaths in the U.S. So certainly it's a huge shortcoming and something that many of us have encountered on a personal level. So this ushers us into an era of blood-based assays in the clinic. So blood-based genomic tests are designed on the principle that all tumors have shared biological features with a common set of cellular products that shed into the bloodstream. And this biology allows us to detect a cellular signature associated with many different types of cancers. And because of this, these tests are intended to be used and evaluated as a single integrated test that can screen for many cancers. And these tests are able to detect the presence of multiple cancer types through the identification analysis of circulating tumor DNA or cell-free DNA, circulating tumor cells, and other exotic markers. And currently, within the US, the only FDA-approved assay for blood-based genomic testing is in the post-treatment setting, looking at minimal residual disease and prognostication and decision-making for adjuvant therapies. But largely my talk here will be ushering in these blood-based genomic tests before diagnosis as a cancer screening test. So there are some requirements that we need to see in these multi-cancer detection tests for them to be feasible and usable in a population on a population basis. So first of all, low false positives to minimize unnecessary workup are paramount. You can imagine the chaos that would ensue if there was only a 5% positive predictive value for these tests and people were getting unnecessary diagnostic workups up and down the body due to these multi-cancer early detection tests. So, and you'll see this as a theme moving forward in my talk. These tests are largely pegged to have a very high specificity, meaning the number of false positives are low. The positive predictive value, or the likelihood that a positive test shows a cancer, is high. But there's always a trade-off with cancer screening. And with that trade-off, there's limited sensitivity and potential missed opportunities for detection. These tests need to detect early-stage cancers across major tumor types, identify those cancers that will impact survival. It'd be nice to avoid detection of pre-malignant or benign tumors. And it can be helpful if the test is able to not only tell you if there's a suspicion for cancer, but also where that cancer could be coming from to help guide your diagnostic workup. Again, these tests are not diagnostic. They provide clues to a possible cancer. And even with this kind of trade-off between specificity and sensitivity, given that feasible screening tests are lacking for most cancers, even a test with suboptimal sensitivity may be an improvement over nothing. So multi-cancer detection tests largely utilize cell-free DNA to identify the cellular signature for cancers. And the one aspect of cellular-free DNA that is kind of rising to the top as the most significant and the most helpful in this approach is cell-free DNA methylation. And this is a really promising approach with these tests. And it's based on the analysis of the epigenetic changes on the DNA that occur in the cancer cells, and that can be detected in the bloodstream. You can see in this schematic here, these are circulating tumor DNA methylation profiles, example profiles for two different patients, the top patient being a cancer patient, the bottom patient being a lung cancer patient. And you can see that these methylation profiles in some way provide kind of like a QR code for a particular person's, cellular signature within their bloodstream. And through early studies within the pipeline, enrolling tens of thousands of patients, both normal healthy participants and participants with known cancer diagnoses, we can run the ctDNA methylation profile, put this into a machine learning algorithm, and allow the AI machine learning algorithm to identify these types of patterns in these QR codes that are invisible to our eyes. And through this training, we're now able to provide de novo samples into these processes to give us a clue whether or not the cancer is coming, whether or not the patient has cancer, and methylation profiles differ based on cancer origin. So now we can also predict where the cancer is potentially coming from. There are a multitude of companies that are rushing to try to develop a multi-cancer early detection test. This is a slide you'll see in many MCED talks that's made by the NCI. Largely, I'll be talking about two tests from two different companies, not because I have any conflicts there, but because this is where the prospective data lies in 2026. And those two companies are Exact Sciences, who have a test called CancerGuard, used to be called CancerSeek. And the other company is Grail, that has a multi-cancer early detection test called Gallery. And both of these tests, like I mentioned, use machine learning AI-style analytic engines to use data that comes out of the blood to classify a patient as having cancer or not. The DETECT-A study was published in Science in 2020, and this is the predecessor to Exact's CancerGuard test. This study was published before Exact acquired this company. This is a multi-center prospective trial in 10,000 healthy women, ages 65 to 75, without a known history of cancer. And this test was to examine the feasibility of their multi-cancer early detection test coupled with PET-CT imaging. They specifically enrolled women because they were hoping to enrich for ovarian cancer cases, one of those cancers that don't have screening modalities, that are insidious on onset, that early detection can certainly help improve outcomes. So in this study, 10,000 women were screened. 490 were positive on a baseline test. They had a reflex kind of secondary test. 134 were positive on the secondary test. And from that, 127 were recommended for PET-CT imaging. The DETECT-A study and now the CancerGuard test does not provide a cancer signal origin. So their recommended workup for a signal positive finding is to provide a whole body PET-CT. In this study, 26 cancers were detected with the test. In total, in the follow-up period, 96 cancers were detected. 26 of those were detected with the multi-cancer early detection test. Another 24 were detected by standard of care screening, and 48 were detected with neither approach, either tumors found incidentally or clinical presentations. You can see the breakdown of the different types of cancers that were identified in that figure there. And the majority of the cancers were between stages 1 and 3. Looking at the 2x2 table, the positive predictive value of this test, or the probability a person with a positive test has a cancer, was around 20%. And the sensitivity was around 30%. And you'll kind of see that sensitivity around 30 to 40% replicated in other studies that I'll be showing you too. They are working on further fine-tuning this test by, providing a further multi-omic approach to cancer screening, and they've shown that, in addition to methylation, when you add other markers such as proteins, mutational analysis, and aneuploidy analysis, you can improve both on the specificity, or you can improve on the sensitivity of the test. That's CancerSeek, now called CancerGuard. That's the only published prospective data we have right now on the test. They're actively enrolling on a prospective clinical trial called the Falcon trial. It's a single-arm study, but there's a comparison with real-world data looking at outcomes for patients who have not received the blood test, patients that are basically identified for the electronic health record. It's not a randomized study. Next, I'll be talking about the Gallery test, which is developed by Grail. This test only is looking at circulating tumor methylation profiles. In comparison to the CancerGuard test, when you get a signal positive finding with the Gallery test, you also get up to 2 cancer signal origins that can help the providers to hone in on the diagnostic workup. And on the latest iteration of Gallery, they've actually whittled that down to a single cancer signal origin prediction. This is from the study that led to the development of the Gallery test, and these are all patients with known cancers who had their blood drawn before treatment, looking at the sensitivity of the test, calling that cancer. And you can see from this chart here, the test is pretty excellent with sensitivity for various GI cancers, pancreas, colorectal, esophagus. Also very effective at identifying head and neck cancers and hepatobiliary cancers. You can see here the test was not very helpful in identifying certainly thyroid cancers, prostate, or breast cancers. This data is further divided out by stage based on the disease site, and you can still see that for various GI malignancies such as stage 1 pancreatic cancers, numbers are small, but the sensitivity is exciting and optimistic. And then you can see for early stage breast cancers, early stage lung cancers, test is not very good. This is largely due to volume of circulating tumor DNA being shed into the bloodstream. This is the original Pathfinder study, Pathfinder 1, that's been published in The Lancet in 2023. Dr. Tom Baer at OHSU was our site principal investigator for this and presented the initial results at ESMO in 2022. This was the first prospective study of the Gallery multi-cancer early detection tests. These are all healthy individuals over the age of 50, 6,600 people enrolled. OHSU enrolled a quarter of all patients on the study. This was a multi-site US study. Out of all those patients, 92 or 1.4% received a phone call saying that their cancer signal was positive and they need to do additional workup. The other 99% received a no cancer signal detected result and recommend to proceed with recommended cancer screening strategies from their primary care providers. The 2x2 here showed pretty similar numbers to the CancerSeek study, positive predictive value of 38%, very high specificity, again, by design. The thresholds and the cutoffs for these tests are placed such that they will have a high specificity and in turn sensitivity struggles. And the sensitivity for a 1-year follow-up period was 30%, 28.9%. So this leads us into the Pathfinder 2 study. So this is the next generation iteration of the Gallery multi-cancer early detection test. This is a much larger, much more representative population within the US. And this is a registrational study that Grail has submitted as of a month ago for FDA approval for this test. I presented the preliminary analysis of the first 25,000 patients at ESMO in October. And these are the slides from that presentation. So multi-center study, 32 North American healthcare systems. And rather than the 1-year follow-up in the Pathfinder study, all patients here have a 3-year follow-up. And those who have a cancer positive signal undergo protocol specified workup based on the cancer signal origin prediction. And before anybody's deemed a false positive, a protocol specified PET-CT is obtained, but that PET-CT up front is at the discretion of the provider, but is mandatory at the end before you deem somebody a false positive. These are the demographics from the study. Again, this is the first 25,000 people with 1-year follow-up, and you can see that it's a pretty representative population across age, race, ethnicity, to be eligible for the study, again, you have to be 50 and over, no clinical suspicion of cancer, but cancer survivors were eligible. You had to be at least 3 years from treatment, and about 10% of people had previous cancer histories. The cancer signal detection rate was around 1% again. 216 people received a phone call saying that their test was positive. And the positive predictive value of this test was quite a bit higher than the previous studies, 62%. So meaning, 6 out of 10 people who had a positive test ended up having a cancer that was found in like I mentioned previously, that's orders of magnitude higher than what we're used to with colonoscopy mammography, which are in the 5% range. Specificity again was very high, and the sensitivity for that 1 year period was 40%. Subdividing the cancers into different kind of clinically relevant subgroups. For the 12 cancers responsible for 2/3 of US cancer deaths, the sensitivity was 74%, 72% for 6 aggressive cancers with low 5-year survival, and 55% for cancers without recommended screening strategies. During this 1 year follow-up period, 329 people were diagnosed with cancer. 200 of them, or 61% of those, were screen detected cancers. And further looking at the screen detected cancers, the multi-cancer early detection test identified 133 cancers. And when combined with the 20 cancers that were signal negative but found through U.S. Preventive Service Task Force A and B recommended cancer strategies of those 20 patients, the MSET test had a 7-fold increase in the number of screen detected cancers. And when adding 47 screen detected prostate cancers, that the test increased the number of screen detected cancers by 3-fold. Here's the breakdown of the different disease sites of cancers that were identified by the multi-cancer early detection test, both solid cancers and hematological cancers. There are some exotic cancers such as testicular cancer, which came from our site. 133 patients again were diagnosed with cancers. 114 were new primaries, and actually 18 were recurrent cancers. Many of those recurrent breast cancers that were unknown to the patient or the clinical team. And 3/4 of all MSED detected cancers do not have recommended screening strategies. As far as stage distribution of cancers, the majority were early stage. 69% were between stage 1 and 3, and 54% were between stage 1 and 2. And then of those stage 1 and 2, 3/4 of those, again, don't have recommended screening strategies. And as was clear from one of their earlier studies looking at the sensitivities by disease site, this very much kind of matches what they've shown in their early studies. There are, a multitude of head and neck cancers, hepatobiliary, GI cancers that were identified on the study. The time to diagnostic resolution, meaning the time from the signal detection to when the provider said that enough workup has been done, was 36 days for true positives. It was 75 days for false positives. That makes sense because with patients that you can't find cancers, you're kind of taking a stepwise approach, trying to turn over every stone that you can. For those true positives, the prediction of the cancer signal origin by the test was 92% accurate. So those folks with true positives, 92% of the time, the test was accurately able to identify which organ site the cancer was coming from. The test was safe. This is a blood test. Less than 1% of all participants, of all 25,000 participants, had an invasive procedure to evaluate a positive MSET test result. These are the different kind of diagnostic procedures that underwent. Both the blue lines are the true positives, the gray lines are the false positives. That is, the majority of examinations were non-invasive, lab tests, imaging tests, non-invasive procedures. The patients with true positives had more invasive procedures, which include needle biopsy, than those with false positives. There were 4 false positives that ended up having a surgery based on a positive multi-cancer detection result. And those 4 were either for benign conditions or infections that needed surgical clearance to prove. So the summary from the Pathfinder 2 study is that the MSET test detected 7-fold more cancers when combined with recommended screening, had a robust performance with 62% positive predictive value, much higher than previous studies for the MSET test, much higher than what we're normally used to, and it was found to be safe. So after this presentation, our abstract got a lot of international press, and it was really exciting talking to all these different international websites and news programs. Certainly a lot of promise, a lot of hope. There's also a lot of concern and consternation that these tests may potentially worsen outcomes, cause harm, provide false reassurance. And there's a lot of debate, and both sides have certainly valid valid points. This is speaking real briefly on our team at OHSU, just because I like bragging about them and the work they've done. This is our team of clinical trial coordinators, and here at the front is Diana Poster, clinical research manager. This is a picture we took after we enrolled our 5,000th patient. On the Pathfinder 2 study, we enrolled 6,100 patients, the highest enrolling site in the US, 1,000 or so more than the second leading site, which was Mayo Clinic. We did this through a multitude of partnerships. Oh, sorry. That's just a WebEx AI thing that's talking to me. I hadn't seen that before. Sorry about that. We did this through a multitude of partnerships. We have both arrangements with other healthcare systems throughout Oregon to enroll patients from those populations. We also have coordinators that are positioned in rural places such as Coos Bay. We have an OHSU employee coordinator that lives in Roversburg, that has a mother who lives in Coos Bay who spends part-time in both those communities enrolling patients on these studies. And because of that representation throughout Oregon, we were able to make the Pathfinder 2 study much more representative of the true Oregon population as compared to the Pathfinder 1 study. This chart on the left are the 1,600 patients enrolled on the Pathfinder 1 study. You can see a very heavy cluster around Portland, and looking at the demographics, these are largely white participants. Whereas the Pathfinder 2 study, we really distributed our efforts across the state, and we're able to more closely match the actual Oregon demographics. And actually, because of our work in Southern Oregon as well as the Columbia Gorge area, we were one of the highest enrolling sites for Native Americans. We've had multiple outreach efforts with various community groups. This is the Bethel Emmanuel Church Men's Health Group, and I've participated in their discussions a couple times, and always bring it back to cancer screening, and we have pamphlets available for folks interested in clinical research. We advertise through social media. We've had such a backlog of patients and so much interest in these types of studies that Grail actually sent out their mobile phlebotomy unit for us to do draw days at various communities across Oregon. This unit here was in Roseburg for a week, the Dalles for the week, and Coos Bay for a week. So the outlook for the Gallery test has been submitted for FDA approval a couple months ago. There is legislation in Congress that has been signed as of a month ago, where when these tests are FDA approved, Medicare will cover it starting by 2028. So that has happened, and that has been a huge bar for these tests. The NHS Gallery study. So this is a randomized controlled trial in the NHS system in the UK. They randomized 140,000 people to standard of care screening versus standard of care screening plus a Gallery blood test. They enrolled 140,000 people in 11 months. And there's some debate and talk that this might be the largest and fastest accruing randomized controlled trial ever. There's thoughts that the Salk polio trials, maybe 100 years ago, enrolled more people more quickly. And what they were doing at that point is they were randomizing whole schools across the US for that study. As of today, and this is just actually like hot off the press today, Grail has released a press release showing that the study failed to meet its primary endpoint. The primary endpoint was a stage shift between the two arms, with the hypothesis that the group getting the blood test have less stage 3 and 4 cancers identified. What has been shown is that both arms had a lot of stage 3 cancers identified, and that endpoint kind of washed out. They are kind of teasing things apart a little bit and showing that there was a decrease in stage 4 diagnoses with patients that got the test as compared to those that didn't get the test. And this endpoint of the stage shift is a surrogate endpoint. The gold standard would be an overall survival or cancer-specific survival endpoint. This is a way to get at that answer potentially more quickly, using stage as a surrogate for survival. We all know, I mean, this is the GI group. Stage 3 rectal cancers are incredibly curable cancers. We cure them all the time. It's not a loss if you identify a stage 3 rectal cancer. It's not a loss if you identify a stage 3 lung cancer or head and neck cancer. but those were included in the group that you didn't want to find. So I think there's gonna be a lot of discussion here. Both the Pathfinder 2 final results and the NHS Gallery study will be presented at ASCO this summer, and we're planning a kind of a tandem publication, hopefully in a leading journal later this summer. So there's certainly harms of multi-cancer early detection screening, especially with early adoption of it. There's a concern for overdiagnosis. There's a concern for detection of indolent cancers or those detected shortly before patients die from other causes. Thankfully, I guess this test isn't great at picking up prostate cancer, so we don't have to worry about this test, worsening the overdiagnosis situation with prostate cancers. I would say the other kind of poster child for overdiagnosis with these types of tests are low-grade indolent lymphomas or CLLs, which we see a lot of times incidentally in our elderly patients. And certainly that may add a level of anxiety to folks. But as far as harm to the patient with these types of diagnoses, I'm a radiation oncologist that also treats lymphoma. And the options for these patients are either extremely low dose radiation, very tolerable anti-CD20 rituximab therapy, or observation most of the time. So it's hard for me to make, as a clinician seeing and treating, these indolent lymphomas, it's tough for me to be too worried about overdiagnosing those cancers and kind of, throwing everything else, away. We've shown with the Pathfinder 2 study that unnecessary workup and diagnostic harms are minimal, especially when there's a cancer signal origin prediction. Because the sensitivity is low, at 30-40%. This is not a replacement for those other tests that we know have super high sensitivity that are guideline recommended, and it's part of the scripts of our clinical trial team to make sure patients understand this so they don't skip out on their colonoscopy or mammogram if they have a negative test. And there's also a worry that early adoption, specifically in the US, for tests like this may potentially exacerbate health inequities. This test is not FDA approved, it's not covered by insurance. However, it's available commercially for patients to purchase out of pocket. Thankfully at OHSU, since 2019, we've had clinical trials available for folks to enroll without any cost to them. But one of the slides I had in the Super Bowl this a couple weeks ago, there's a company, Him and Hers, that's kind of this concierge type online company that does everything from hair loss pills to hormonal treatments, who are now advertising these types of multi-cancer early detection tests. And I think there's certainly worry with this type of early adoption, and unfortunately the cat's already loose. At OHSU, we have a multitude of early detection clinical studies all across the pipeline that we are enrolling on, and this slide is, I guess, a little misplaced. So going to the patient that I presented at the beginning, the intrahepatic cholangiocarcinoma that we currently don't have any screening tests for. This is actually a patient who was on the Pathfinder 2 study, who had a signal positive for hepatobiliary cancer. They're a retired family practice provider, completely asymptomatic, found out about the Pathfinder study through social media. He volunteers his time at OHSU with medical student clinical skills and is just always interested in participating in clinical research. Upon identification of this test, one of the first things we did was get a contrast-enhanced CT scan identifying this intrahepatic cholangiocarcinoma. We proved that it's not a metastatic colon cancer with a negative colonoscopy, and he had a curative resection. The alternatives, again, I think for this patient were to not know about this, to proceed for another 6 months to a year, and then present one day in the ER with painless jaundice and a 8-centimeter mass that's encroaching and involving the hilum, making it unresectable. He got a margin negative resection. Adjuvant therapy was offered but declined ultimately, and he's doing great. And he's climbing Mauna Kea and living his life. This is Dr. Weingarten. He's a huge advocate for cancer screening, and we've gotten all the releases to share his story and his information. So then I'm going to go through some other. We have some time. Yeah, we have some time, so I'm going to go through some other interesting vignettes from our early detection trials. This is a patient who uh, was interested in the clinical trial because they were interestingly worried about colon cancer. So they wanted to enroll on a multi-cancer early detection study because they're worried about colon cancer. Um, the test was positive for breast cancer, and we found an early stage breast cancer with this test. Certainly, there are better screening tests both for breast cancer and colon cancer. Nonetheless, even though the test is the sensitivity for breast cancers is poor because the prevalence of breast cancers are so high, we've been picking up breast cancers on this study. This is a patient who had a signal positive, and again, every one of these patients I'm presenting are asymptomatic except for one of them. This patient had a signal positive for head and neck cancer, and on CT imaging, he had a very small left neck cystic node. And, I would say in normal practice, if a finding like this is found incidentally, one may shrug it off and or follow them up with a CT scan in a couple months. But I presented this to Pete Anderson, one of our head and neck surgeons, and I informed him about the positive predictive value for the Pathfinder 1 study, which was the best study we had at the time, showing that this patient has a 40% chance of having a cancer. Endoscopy was negative. He had no mucosal disease. So Pete Anderson performed, and this was too deep for a needle biopsy, he performed a neck dissection and ultimately found a P16 positive HPV squamous cell cancer in the small lymph node. This is an interesting case because, again, there was no mucosal disease that was found. And in radiation oncology, when we have what we call a head and neck cancer of unknown primary, a lot of times we treat them with this kind of full meal deal chemo and radiation covering the tonsils, the nasopharynx, the posterior pharynx. And my thought is that this might be a failure of early detection, because if this patient would have presented with a tonsillar stage 3 HPV positive head and neck cancer, his curability of the disease would have been just as good. So because we were able to find that mucosal disease, he got a pretty morbid treatment. This is a patient that had a signal positive finding for lymphoma, was found to have a stage 2 non-classical nodular lymphocyte predominant Hodgkin's lymphoma, and received chemotherapy for it. I presented a multitude of cases at our liver tumor board. These are one of the patients identified to have a hepatocellular carcinoma, and they came into our clinic and received radiation therapy. This is a patient who had a lymphoid signal and had a single small FDG avid lymph node in the left groin. There's not many cancers that I usually start with a PET CT except for a lymphoid signal origin. And this is really the only finding. Radiologist was able to get a needle in it and was deemed to be a stage 1 follicular lymphoma. This patient also received definitive radiation. This case is really interesting. This is a patient who had a previous gastric bypass surgery, who had a signal positive for gastroesophageal or colorectal cancer. And colonoscopy was negative. Upper endoscopy was only able to examine that more proximal portion of the stomach because the rest of it was bypassed. And per protocol, before we called this a false positive, we got a PET CT because that upper endoscopy, that limited endoscopy, didn't see anything. The PET CT revealed this FDG avidity in the gastric antrum, and it's pretty strong. You may shrug your shoulders and say this could be maybe physiologic, but because of the positive predictive value of the test and because of the accuracy of the cancer signal origin, I reviewed this with our gastroenterology colleagues. We, in the operating room, performed a double balloon enteroscopy to kind of loop back and biopsy and examine that portion of the bypass stomach. And this patient was found to have a gastric adenocarcinoma in that FDG avid area. They received curative gastrectomy, were found to have some lymph nodes on the pathology, and have just finished their post-operative chemotherapy. There's certainly stage 4 cancers that are found with the Gallery test. This is a patient that was bouncing in and out of emergency rooms in the Columbia River Gorge due to back pain and shoulder pain, and never really given the full attention. She was just kind of tired of everything, found out about the study, enrolled in the study, and immediately we found out that she had a stage 4 non-small cell lung cancer. So I don't think this really necessarily speaks to the advantages of this test in this population. Rather, it's demonstrating kind of our broken healthcare system. This is a patient, and I believe Liana did this scope. This is a patient who had uh, again, asymptomatic, had a cancer signal origin, again, for the colorectal, gastroesophageal origin. While getting him into a colonoscopy, I got a CT scan which showed multiple hypodensities in the liver. CEA was elevated in the teens or so, so I was worried this was something real and maybe metastatic disease. Colonoscopy showed a nearly obstructing hepatic flexure mass, and the patient was asymptomatic, still passing stools, and was able to start palliative chemotherapy right away. I think and this is a stage 4 diagnosis. These are one of those cases who, with that NHS study, would be deemed a failure. That this is a state, late stage, not an early stage cancer. But I don't think any of us can argue that identifying this before obstruction or perforation was advantageous for this person to live a better life and actually get the treatment that he needed. We've had a couple really interesting situations with false positives that ultimately matured into a cancer for what we had called a false positive. So this is a patient who had a lymphoid signal, who had a complete workup, including a PET scan. He also had a benign nasal mass, and we sent him to ENT. ENT even did a laryngoscopy at the time. Didn't see anything. We called it a false positive. Less than a year later, he presents clinically with sore throat and is found to have a stage 2 diffuse large B-cell lymphoma. So this is illustrating that these tests, in some patients, for some diseases, the sensitivity exceeds the sensitivity of our imaging modalities, and it's a little worrisome and scary, honestly. So currently, in the current climate, if somebody is deemed to have a false positive on this test, low numbers, but on the commercial side, there's data identifying that if you have a false positive and then a retest in 3 to 6 months, if that retest is then negative, the likelihood that you'll have a cancer in their follow-up period, which is a couple of years, was pretty much 0. But if you have a false positive and then on retest you have another positive, there's roughly a 30% chance you'll have a cancer. So for those patients, we will refresh all of the diagnostic workup to see if the test was just more sensitive than our imaging tools were at the time. So in conclusion, I believe blood-based MSED assays are positioned to potentially complement current screening efforts. Again, as of today, there's data from the NHS showing that the primary endpoint that they decided to use didn't meet. I think that may potentially impact the ability for the NHS system to provide these tests, maybe. I do think that in the US, FDA approval is not so tied to the clinical utility like this. And because that legislation and because the test has been shown to be safe and does what, Grail says it will do, I think that it will get FDA approved and ultimately covered by insurance. We have a clinical trial at OHSU right now looking at a comparison. So there's more data still maturing that hopefully will shed more light to it. We have a comparative study at OHSU called the REACH study, which has similar inclusion criteria to the Pathfinder 2 study, except that it's a study that's actually paid for by Medicare. And to be eligible, you have to have no clinical suspicion of cancer or cancer within the last 3 years and a Medicare beneficiary. And the study is looking to enroll 45,000 people in the US and will be compared to a synthetically generated arm of folks who never got the test. These are people that are kind of mined through the EHR, kind of matched, propensity matching. This REACH study is a fantastic study to consider for cancer survivors. I have a multitude of GI cancer patients who are 3+ years out from treatment, who I'm wanting to kind of escalate down their surveillance, and providing this type of study just adds a little bit of reassurance on both sides. And on the REACH study, they get annual multi-cancer early detection tests for 3 years paid for by Medicare. Findings from the early trials have revealed very high specificity, again by design, with the trade-off that many true positives are missed. The sensitivity struggles, and because of that, these tests, will not replace, but maybe complement existing single organ screening methodologies. Final reports of randomized controlled trials are pending, although there's commercial efforts potentially undermining those efforts. Radiation oncologists, surgical oncologists, I believe, can serve an essential role in helping patients adjudicate these positive results. One thing that I've struggled with, and I haven't had an issue with anybody on this call, but there is a tendency for folks not to see cancer patients or folks with clinical suspicion of cancer without a cancer diagnosis. And there certainly is a role for oncologists to team up with our PCPs or have our PCPs hand off these patients to help adjudicate and work up these signal positive findings, because I can't imagine being a primary care provider in Klamath Falls knowing what to do with a signal positive hepatobiliary signal. So there certainly is a role for, certainly tertiary centers, academic centers to serve as a center of excellence for working up these patients. Thanks.
That's always fantastic, Nima. I don't know, Dr. Wanapa, if you want to go ahead and ask our Thai colleagues if they have any questions.
Yes. Can I start from BHQ first? Dr. Wood and Dr. Tirada, you have any question for Dr. Nima? Okay, never mind. I think someone is quiet. It's still sleepy time in the morning. Ajahn Ton, any question from you,ไหมคะ?
Thank you for the lecture, but I don't have any question. Thank you very much.
Yeah,
About
I'll
other-
add, there's actually some, I forgot to mention this. Grail is partnering with Samsung in Asia on figuring out a way to provide tests and provide, put patients on clinical trials. And I'm not really sure what their approach or aims are, but it is clear from multiple press releases I've seen that there is a high level and high dollar partnership with Samsung to roll out these tests in Asia.
High dollar. Can I ask you a question, Nima? This is what I think definitely all those studies have pushed the needle of how we're going to be detecting cancer. We've been saying it now for decades. We want to do it easier for our patients, more feasible, more affordable, but you kind of alluded to it, bringing Samsung in. I can see Amazon. I can see all these very big Mathusalas, of money and coming in and taking over without the knowledge, without your care, and it makes me nervous. I don't know if you want to speak to this. You kind of alluded again about him and hers. We see the ads on TV here in the States all the time now, and I don't know. It makes me a little bit hesitant to say let's go ahead and do it if it's not offered by us.
Yeah. I mean, so these tests right now in the U.S., the price, depending on the contract and your arrangements with Grail, are between $750 to $1,000 a test. So certainly there's a lot of money to be made. I do feel, because the Pathfinder 2 study showed that the test is safe and the harms are minimal and we're picking up novel cancers. I mean, if these tests were $5 to $10 each, I don't think much of anybody would have a major concern with providing them, as long as the systems are in place to get patients through diagnostic workup in an expedient way. I mean, the last thing you want is somebody have a signal positive finding, but gets bounced around for 9 months through multiple providers trying to figure out how to work up their cancer. So there's certainly efforts in creating centers of excellence where patients can get referred to with signal positive findings. Those percentages are pretty low. Again, about 1% of people have a positive finding, so the volume hasn't been excessive for OHSU yet. Yeah, I mean, it's a challenge with the U.S. system. I mean, in the NHS, they've taken a very deliberate approach, looking to develop the data, provide strict kind of endpoints to either use that evidence to either recommend or not recommend these types of screening tests. in some ways, that approach is very conservative. Our approach is very liberal, and I think there's a medium ground that I haven't yet been able to see happen. So it's an interesting space, and it's changing it like every month, it seems like.
Nima, this is perhaps a very different angle on this, but is there any thought of these tests? I mean, obviously they're looking at an older population, but AYA and kind of cancers in young people are increasing of concern, but like working or the screening tests are risky and expensive. So
yeah, I mean, so these companies right now are putting all of their capital into the gold price, which is general population screening with age being the risk factor. And it's clear that that's how they're going to make the most money. But I don't think there's any argument that these tests are better utilized in certain populations, such as those with like genetic predispositions to cancer, those who are on chronic immunosuppression, cancer survivors. These companies aren't putting their money into those types of studies, so it's really incumbent on academia to do that. And we actually are, it's in the IRB phase right now, but we're collaborating with Dana-Farber to provide multi-cancer early detection tests to those patients identified in the HOP database who have genetic predisposition to cancers. We haven't yet had an intervention for anybody on HOP. So really excited to do that. And one of the questions I get asked, going back to your main question, Will, I get asked all the time from folks younger than 50, like, why can't 40-year-olds, why can't 30-year-olds get these tests? And I never have a good answer other than the company set a cutoff of 50 years old as a cutoff for age as high risk, and that's kind of where it's at. I mean, the label right now for the test is the same as the clinical trials, those who are 50 without clinical suspicion of cancer. But I think in practice, anybody who wants the test can get the test the way it is right now, self-pay.
I'd like to, I personally would like to try it myself. Hearing this. Okay, just one last question around for the nurse. Anyone want to ask Dr. Nima before we finish? We still have some few minutes time. Yep. มีคำถามไหมคะกรุณาอย่าอาย